Everyone, this is Grace Peng from the Interagency Modeling and Analysis Group, and we continue on our pre-meeting webinar series for the Interagency Modeling and Analysis Group Conference on integrating machine learning with multiscale modeling. I'm happy to introduce one of our IMAG representatives, Lieutenant Commander Rachel Slayton from the CDC, who will be introducing our speakers today to focus on the areas of human safety.
Thank you, Grace. We're excited today to have Dr. Ailey Klein, who is a fellow at the Center for Disease Dynamics, Economics, and Policy, and is an assistant professor in the Department of Emergency Medicine at Johns Hopkins, presenting today. Dr. Klein has authored numerous publications on the evolution and spread of antimicrobial drug resistance, in particular with reference to the emergence of antibiotic and anti-malarial drug resistance. So I'll turn it over to Ailey to introduce his colleague, Dr. Scott Levin, as well.
Thank you, Rachel. Thank you, everyone, for tuning into this webinar. We're discussing today about using machine learning in actual processes in the hospital. In part because machine learning is, as everyone has discussed, and probably why you're coming is because it's discussed as sort of a panacea to solve all the problems in healthcare. And what we're going to discuss today is sort of the use of machine learning to improve operations within the hospital with a goal of improving patient. And a second application that's using machine learning to improve identification of patients asymptomatically colonized with resistant bacteria that is ongoing. And both of these will show sort of the ability of machine learning to predict events or to predict important patient safety outcomes. But they also show that these require that they be applied within the context of healthcare, and that, in other words, that they can't really be standalone applications, but can help augment care and rather than replacing care. So as a first part of this, Dr. Scott Levin, who's an associate professor at Johns Hopkins in the emergency department, is going to present on some of the work he's done on improving triage of patients entering the hospital. Scott?
Yep, thanks, Ailey. First, I just want to really quickly disclose that the technology that I'm going to describe has been commercialized through a company that is affiliated with Johns Hopkins, and that Johns Hopkins and the company and my relationship has all been approved. And so they're in accordance with conflict of interest policies. So I just wanted to get that out of the way, but if you can go to the next. So we built this machine learning based technology called E-Triage to tackle the problem of emergency department crowding. So many of you who've experienced a visit to the emergency department know that there's a big problem with ED crowding, and there's consequential delays, particularly for those critically ill. And so this crowding has been linked to patient safety and health outcomes. And at the same time, there's a lot of folks visiting the emergency department for non-urgent reasons, and there's some evidence to suggest that the ED, treats 30 to 56% non-urgent visits, which can lead to overutilization and wasteful spending. Go to the next. Can you go next, Ailey? Oh yeah, one back. Sorry. So one of the first clinical process that happens to patients in the emergency department is triage. That's when the patient first arrives, and a nurse or physician collects patients' vital signs, asks why they're there, and also gets basic demographics and information about the patient in order to assess how quickly they need to be seen. So some of the things that is little known about triage is that it's a major trajectory setter in the emergency department. So based on what triage level you're given, you may go to different areas of the emergency department and may be seen by different levels of providers based on triage. Further, a panel from the American College of Emergency Physicians has recognized triage as one of the most important determinants of the ultimate disposition decision important in emergency medicine, which is whether to send the patient home back to the community or to admit them to the hospital. You can go ahead next. This is the current standard for triage across the country. A patient arrives and a nurse quickly collects the information that I mentioned and will triage the patient to a level 1 if the patient is dying, level 2 if they believe that the patient is not safe to wait. They'll triage the patient to level 4 or 5 if they're fairly sure that the patient is low risk and will not require a lot of resources in the ED. And then, but patients where their projected clinical course is somewhat uncertain, they'll triage to a level 3. Some characteristics of this triage algorithm, again called the Emergency Severity Index, is that it's very, very subjective, as you can see, particularly with level 1 and 2, and has some limited validation against actual outcomes and the inter-rater reliability. So a nurse triaging the same patient the same way, that agreement rate is highly variable. You can go on to the next. So another issue with the Emergency Severity Index is that it's somewhat antiquated. It was developed, well over 20 years ago, when less resources were being used in the ED, and now many resources tend to be used for all patients. And so, as a result, you have this system that's designed to triage and differentiate patients, and a large heterogeneous group is bucketed into level 3, the one where there is uncertain projected clinical course, as you can see from the plots on the bottom. So again, we have this objective of differentiating patients, but the current standard struggles to do that. So to solve this problem, we created a machine learning decision support tool that actually takes the predictor variables, all routinely available at triage, chief complaint vitals. It scrapes the patient's medical surgical history in the EMR and estimates a risk of critical care, emergent procedure, and hospital admission, as you can see defined on this slide. If you go to the next. Based on the risk predicted for each patient, this tool is running in real time, and when that predictor information is entered, within a few seconds, a recommendation is provided back in the electronic health record, and the screen looks like this. This is really embedded into several EHR systems, but essentially there's an E-Triage acuity recommendation at the top, and you can see with the definitions of what that means. There is some information about why in the E-Triage supplement about why that patient was triaged to that particular level, and then at the bottom is actually where the triage acuity is assigned. So the nurse or physician working in triage will still assign acuity similar to they always have, but now they have decision support kind of right in front of them at the point in time when they're making that decision. So what happened when we introduced this tool into Johns Hopkins East Baltimore Emergency Department is you can see here the levels 1s and 2s above in the first plot kind of stayed similar by design, but what we wanted to do is really reduce the proportion of level 3s, and so we did see an 18% reduction in level 3s, and you could see post-intervention, the blue plot. And also the proportion of level 4s and 5s, patients that are deemed to be lower risk and safe to fast track, were increased about 55 or 61%. Go to next. Some of the outcomes associated with the technology were were assessed pre and post, and the major things of importance were improved speed to the critically ill patient. So we saw a 45-minute reduction from door to ICU, which we know is linked to morbidity and mortality, according to many studies that have looked at this. There's also a 94-minute reduction from door to ED departure. So overall, as a result of separating the low-risk patients, kind of separating some of the signal from the noise at a system level, ED providers are able to get to the sickest patients, those critically ill, and also those that are ultimately admitted, when there was a reduction of 42 minutes, faster than they were before. Of course, there's limitations with this, and that this was a pre-post study, and there may be other confounders that influence these data. But we feel that the only major intervention that occurred between these time periods was our change in introduction of our triage technology. Go to the next. Another important characteristic of providing machine learning based decision support that we find in this tool and across all the tools that we've deployed, that the clinician plus the machine learning algorithm tends to be better at the job at hand than the E-Triage algorithm, or the machine learning algorithm alone, or the clinician alone. And so what we're seeing here is essentially the improvements in performance when the two are combined compared to either alone. And we believe that this machine learning technology should very much be should be for decision support and not making any decisions. And in this case, the nurse is able to agree or disagree. And in this case, we have 84% agreement. But there are a lot of things that the nurse or the physician can see that the E-Triage technology can't. And so we always recommend that the clinician uses their clinical judgment in combination with the tool to make decisions. Go ahead to the next. Oh yeah, so finish there. Thank you.
All right, thank you, Scott. And so we used a lot of what Scott had been built up in terms of the development of E-Triage and that machine learning algorithms for looking at a separate problem, but has similar issues, and that's predicting patients colonized with carbapenem-resistant organisms. So CRO infections are typically multi-drug resistant, which makes them very difficult to treat. And invasive infections increase mortality risk by up to 40 to 50% in some studies. The current recommended approach by the CDC to control transmission of these types of organisms is to recognize that they're important, quantify the magnitude of the problem within the facility, and specifically and very importantly, identify colonized and infected patients when present in healthcare facilities, and then implement interventions such as hand washing or contact precautions that can reduce the transmission within the hospital. So the problem is that patients arrive at the hospital, they may be colonized with CRO, and this increases the risks to those patients as well as to other patients. But identification of patients typically occurs when a patient tests positive by antimicrobial susceptibility testing. So they have some sort of infection, and that's what results in defining them as having CRE or having a carbapenem-resistant organism. But that's really just the tip of the iceberg. And the problem is that far numbers of other patients are entering the hospital asymptomatically colonized. And the question is how best to identify those patients. So one mechanism is active surveillance, and this is done in some inpatient units, particularly ICUs. They typically use a rectal or perianal swab to detect gastrointestinal carriage of CRE. Unfortunately, this is quite expensive, it's quite resource intensive, and fairly difficult to implement across an entire institution with every patient coming into the hospital. What we're attempting to introduce is a machine learning algorithm to detect patients entering the hospital with CRO. So as Scott was talking about, we can use different information about the patient when they arrive, including prior medical history that we can scrape from the EHR, as well as specific information about their chief complaint, about what their problem is, and then use machine learning decision type trees to identify patients who might be at high risk for CRO. So at that point, then those patients can be characterized either for additional surveillance, like such as active surveillance, or immediately implemented into precautionaries. into some sort of precautionary program to reduce probability of transmission and probability of risk to themselves of becoming infected. To do this, we've been looking at data from 3 different hospitals, at the Johns Hopkins Medical Center, the University of Maryland, and Imperial College London. And so, again, we're able to look at all sorts of different factors, including age, sex, race, ethnicity, where they're coming from, when were their prior admission and discharge times, how long have they been in the ICU or before the ICU, and this algorithm can run either when someone enters the hospital or when they move into certain units. Unfortunately, at the moment, we don't actually have any preliminary results to show. We have some preliminary tests that suggest that this is going to be effective, but the goal is to have this implemented and running within the hospital in about a year as a similar type of system as E-Triage, which results as decision support, which can then be used to provide additional resources and operations to the hospital to reduce transmission. And with that, I want to thank Rachel for letting us present on sort of the work that we're doing, and to Grace as well. And thank you all for listening.